Yeah. Is the speaker remote today?
Remote today. They were gonna come in person, but travel plans changed.
We got the CZI grant. Chance-Zuckerberg Rare Diseases.
Oh, haven't heard about this one.
Oh, I thought we talked about it in the data science meeting, maybe not.
Rare disease.
Yeah, basically use fiber motor classifiers to find patients with undiagnosed rare diseases.
Cool.
It was funny, the program officer, no, they had an analyst. I think you might even know that guy, Gully Barnes. Have you heard that name?
Over?
Gully Barnes. This is an oncology guy. Known him for like 15, 20 years. Used to be at USC. Going there, was working on this on the side. A result. Then he saw climb brain motor. He invited himself into giving a talk at one of the groups. Oh, and brought his program officer along. And essentially made the pitch to the PO in the meeting saying, this preliminary result we have, these guys should do it.
Okay. I don't know if you need to put out for people, right?
And
I don't know what's your spicy.
after that, the PO collaborated with us to write a 2-page submission. Yesterday, they just,
Right.
no news after that. Yesterday, they just sent a DocuSign. Saying we're awarding you $2 million.
Okay. Nice.
So tonight is like, did you submit the final grant? I was like, there was no final
There
grant.
was no submission, it was just.
There was no submission. And he's like, how did this happen? I was like,
Beans, quinoa, lentils.
We'll get a fork.
I eat eggs, Greek yogurt. I have to buy, I'm thinking I should buy some protein powder. No. I have to, oh yeah, that's what I do. I have to go to grocery
People are
store.
starting to trickle in, we'll give it a couple more minutes before we start formally.
I'm gonna just retest. Can you hear me again? Or no?
Yeah, I
Abby,
can hear
me? Okay, my circuit just went out, so I'm like retesting my audio. I'm on my laptop now.
Oh no.
I know, it just like blew, like everything stopped working, but my laptop.
Oh
has.
no.
I'm here.
Do you have enough battery life?
I think so. If you see me off camera, it's because I'm moving into another room, because the circuit is not.
GSP thing that Abraham.
The light's working.
I did it last year. Well, last year, I don't know, they just invite me once a year and maybe they'll stop inviting me. It's not really a recurring gig necessarily.
They have a couple of these. I did one today. It was not the same one.
We call it paneer, it's like
This is like two other faculty. And then I went to that building, the Patterson building.
spinaches.
It was.
Das war so cool. I'm like, what is this?
They taste very different.
The news office is doing this health futurist. Okay. Technically, you and Nancy is the first resident.
Thursday. And Tuesday.
Always I'm not every Tuesday. There was not this week.
Oh, yeah. Thursday is like every Thursday there is one.
Oh, it's
Tuesday
before
is
it became
usually,
part of
there's, sometimes there is,
What
sometimes there is
happens?
not.
Right.
from the.
Just see what it looks like outside, and then I think we'll formally start in about 60 more seconds.
Okay, so if there is a second every Thursday. Every Thursday. So, but yeah, maybe you can ask Saira, do you know when QAs you start?
It's spicy.
I'm not a cook. I was like.
Ready, Dr. Cunningham, Dr. Falola, can you hear us?
Yes, we can. Sorry, we're not there in person, but
So you
we can hear you.
Next time, we'll see you next time. There's a whole other half of the room you actually can't see. People are continuing to trickle in, logging on, and also sitting down with their lunch. But want to make good use of our time. In the meantime, could you just introduce yourselves? Who are you? Where's your girl? Actually, I'm working on that, and then we'll dive into the formal part in a few minutes.
Sounds good. Well, hi, everyone. I'm Evie Cunningham. I'm an OBGYN physician by training, and I lead virtual care and digital health at Providence. And I'm also the co-founder of MedPearl, which is the product that we're going to be talking to you about today. And joining me as well is Toyin Falola, and I'll let her introduce herself as well.
Hi, nice to meet everybody. The circuit is out in my house, so let's hope my laptop lasts this entire presentation. I'm Toyin. I actually live like down the street from you guys. I live in Belmont, so next time I will definitely come in person. I did my residency at Stanford in dermatology, and then I left clinical practice and have worked at some venture-backed and publicly traded digital health companies. I'm doing product development and clinical product strategy, and I work with under Dr. Cunningham's leadership and Providence's virtual care and digital health organization, where we also incubate and develop products for our caregivers and our patients internally.
Awesome. I see you've got clinical background and training precedent. Was it on purpose to do this kind of digital crossover in your prior life, or was that sort of happenstance that just turned out maybe what did you needed to fulfill your clinical mission?
Oh my gosh, total happenstance. I was seeing patients, and I'm sure Evie will say the same thing, totally just frustrated with things that I saw while I was seeing patients, and then just wanted to develop solutions to help the patients that I was seeing in front of me. And then just, living in the Bay Area, continue to stumble into more opportunities and just went where they led me. And I was just been really lucky. And, training at Stanford, it's always thinking about a problem, trying to solve it, looking at innovation. So it was just a great place to get me into this type of career. I'm sure Evie has a similar story to say.
Yeah, I'm actually going to tell a little bit of that story when I tell you about the product, because I'm going to give you a little bit of a history on the genesis. So you'll hear a little bit, but it's the same thing, like, being on the front lines or leading on the front lines and knowing technology experience could be better, but just is not translating at the industry level. I think it's starting to change. Obviously, we're seeing that happen now. But when we started this journey, there was just a complete disconnect. Yeah.
Fantastic. Sounds like a great segue. I've got a decent quorum now. If you'd like to go ahead and take it away, we're very excited to hear about the work you've done, which is a product company, but also is a very recent research paper as well. And would love to hear more about that. We'll hold most of the QA till the end so that you can get through it, but looking forward to the discussion. Take it away.
I think I shared the wrong screen. Hold on a second. Let me try this one more time.
No, that was the right one. I was seeing.
Oh, it was? It was the
Yeah.
right one? Okay.
Yeah.
Sorry. It just didn't have a box around it. Okay.
Yeah, PowerPoint.
You can see it? Okay.
Yep, perfect.
I might have to stop share to do the demo, but anyways, nice to meet you all. Sorry, we're not there in person. We're gonna talk a little bit about the product. We already did our intros and the problem that we were trying to solve. And then we're gonna give you a live demo of the solution today, and then go into some of our metrics. This all aligns with a lot of what you would see in the New England Journal of Medicine Catalyst paper that was published in August. And then we'll have some time for questions as well at the end. So just to kind of give you an overview of sort of what is under the portfolio of work that I'm responsible for, I have all of the virtual care programs, so our inpatient telemedicine, hospital at home, remote patient monitoring, anything that's clinical sort of innovation, virtual nursing. And then we also have MedPearl, which is the digital product that we're going to talk to you about today. I started out actually not in informatics. I don't have an informatics background. In fact, I shared I'm an OBGYN. I did my residency training at Kaiser Permanente, And then I went to become, eventually moved up the ranks in clinical leadership, leading medical groups. I was a medical group leader at Providence during COVID. It was one of the most intense times of being a chief medical officer of a medical group. And it was during that time that I realized that there was so much, that we were catapulted into this innovation space with COVID and turning on the lights for all the virtual care, but the actual technology experience was just one that was really frustrating for our clinicians. And I wanted to be more than just a messenger. I wanted to be able to translate and advocate and support our clinicians in bringing technology solutions to the point of care that really served their needs and helped them get through their day. And one of the things that was really, really apparent to me, I actually even wrote an article about this in 2020 on Kevin MD. It was just about the vast amount of data that was accumulating on our patients in the patient's charts, and the massive amount of information that was expanding. Medical knowledge is expected to double every 3 months at this point. And it's not really well organized in a meaningful way in the charts. So knowledge and data is still very disparate in when we're going into our EMRs. And so I wanted to find a way for us to be able to bring those two things together in a more meaningful way. So just to talk about the problem that we wanted to solve initially, we started here. So I made the big statement about medical knowledge expanding and patient data being so voluminous. But as a medical group leader, one of the things that I would hear all the time from my constituents and from senior leadership was about the issue around referrals or care transitions between primary care and specialty care. And this is actually a very high strategic priority for health systems because there's a fairly large ROI associated with it. And when you talk to the clinicians, they would say, look, primary care would say, I don't know what the specialists want. I don't know what they want me to do. I don't know which patients are the right patients to send them. I don't know what workup they want, done. Or sometimes the specialist rejects my patient and it pisses the patient off and I don't understand why. So there was that level of frustration and sort of access challenge that primary care was feeling. And then the specialist would complain, I see patients that I don't need to see, or I see patients that see me, but they're supposed to see a different type of specialist, or the patient comes to me and they don't have any workup, or they only have a piece of the workup. And so we knew that if we could address this problem, that there was an opportunity to potentially really open up better access. But unfortunately, the traditional way of solving this problem around referrals was, let's hire more people. Well, there's a shortage of doctors. So how are we going to hire more people? We don't have enough of us. Have them be more productive. Let's have them see more patients because we have these access challenges. And that's just a great way to piss off your clinical workforce that's already burned out. Or let's do a CME or a grand rounds. Well, that's not really scalable. And how do you know that the clinicians are going to retain that information? Let's do mixers. That was the other thing you would hear. That's, again, not scalable. And then another was like, let's do hard stops and, make the clinician or force the clinician to do something, which again is not something that is a super popular thing to do right now. And so we knew that that there was an opportunity, if we could address this problem in a more meaningful way, there was an opportunity to reduce referral leakage, to improve the quality of the referrals, improve the matching of the referrals to the right type of specialists, and ideally to improve the lives of our primary care clinicians who are literally responsible for everything that's in a patient's chart. And so what we wanted to do was create a platform that really encapsulates kind of that interdisciplinary knowledge across the continuum and capture it in a more meaningful way so that it's organized around workflow, that it fits into the workflow, that it serves up the right next best actions and the right information at the right time and aligns with patient clinical context. And so that was sort of the premise and the big idea of what we tried to do. So there were 5 things that we really kind of focused in on when we started to design this solution. Number one, it needed to be a solution that would be integrated into the clinical workflow. Too often, asking clinicians to go out of their workflow to access something or to remember to do something, it's very hard to get adoption that way. We also knew clinical decision support everybody talks about it, but it hadn't been scaled in a meaningful way in most EMR systems. And that's because there wasn't really we're on Epic. There wasn't really a great place for the clinicians to come together and come to consensus about how they wanted to codify a pathway or knowledge and build it in a no-code environment in a meaningful way. And so we needed to be able to create a collaboration platform, a back end where the clinicians could do this in a digital place. The other thing, Toyin's going to talk a little bit about our AI roadmap, but AI wasn't really being used at the time when we started this. We started working on this. I'll talk about the timeline in 2021. And then the other thing is that all the knowledge bases that were out there, you'd have to go look something up. Then you have to go back into the chart to see if these things had been done. Then you go back and look something up. So bringing knowledge and patient data together is what we call contextualization. That was another thing that was really important for us to try to solve with this solution. And I talked a little bit about the governance piece. So we did an innovation lab where we had like in a human-centered design process where we sat down with the clinicians, the frontline clinicians, and said to them, you know that this referral issue is a problem. How do we design a solution around you so that it resonates with you, it meets your needs, it's something that you're going to want to use? And what are the features? What are the things? How do you want it to be organized in a meaningful way? And we spent hundreds of hours and we interviewed clinicians and we went through a whole process of how we sort of did that. And then with any type of product development process, there are many different iterations and versions of product. And so we started, actually, I think the initial conversations around the referrals and the problem there started with envisioning and prototyping with our Microsoft partnership in late 2020, early 21. I actually built a chat bot myself on a no-code bot building platform, loaded in a bunch of referral guidelines that I had harvested from across the system, and actually got 30 docs to pilot it and give me feedback, which then pushed us into an opportunity to experiment with other types of technology solutions that might be more scalable, which we ended up determining was not the right solution. And then that's when we got to MedPearl 1.0, where we actually built the solution from the ground up, from scratch. And we really designed it around what the clinicians said they needed and wanted in a jobs to be done approach. So the product today that's live across Providence, this is the piece that I'm going to demo to you today, which is the clinician UX. And this is the referral guidance. It's got almost 1,000 topics in it now of clinical conditions, diagnostic support to help clinicians in their workflow when they're seeing patients. And it brings really quick guidance that clinicians can navigate through, basically kind of a codification of the massive decision trees that many of our clinicians have in our heads, translated at the point of care, and it's very actionable. It's designed to tell you what you need to do with your patient, not necessarily what you need to know about a condition, but what to do when the patient's in front of you. And then it contextualizes and surfaces the relevant patient data and maps it to the knowledge document. So I'll show you a live demo of that. And then I talked a little bit about what the content creator or the content engine, we're calling it the publisher and context engine. And this is where the clinicians come together to create, collaborate, develop, and maintain digitally consumable content for the point of care consumption. This is almost like what I would describe as a GitHub for doctors. It's a place for them to come together. And it respects governance practices that are very important in clinical care. It has digitally enabled governance practices within it. So I'm going to go ahead and give you a live demo. Can you see? What can you see?
Yeah,
I can see your
right
screen and did you have a question? Were you raising?
Are you seeing the Pearl?
now. Yep,
I-
this
I-
is perfect.
that's what I'm seeing.
Okay,
Pearl specifics. Go ahead.
All right, so I have this, this is expanded at 150%, so it looks a little bit wonky, just because the text, we wanted to make the text bigger, but just to give you, just a background on where I'm orienting you to this. I can't show you the live platform that's live at Providence today because it's inside of Epic and I can't show you our Epic. But if I was in a patient's chart today, just imagine if you were in your patient's chart today, inside the chart, there would be a little button that said Pearl on it. And you could click the button and this application can open up. It opens either in a wireframe or it can pop out. It kind of depends on what the institution wants. And when it opens, it's inside a patient's chart, it's context aware to the patient whose chart it's in. So it knows your patient and it's going to pull the patient's data through a FHIR API feed. So this is a demo environment. Let's just pretend that I saw a 66-year-old man in my clinic, which I don't see men because I'm a gynecologist, but he has some very interesting abnormal labs. And he had come in to see me. He was complaining of fatigue, dry skin, hair loss. I thought maybe I'm going to check a couple different things, including a thyroid level. And lo and behold, his TSH came back really high. And so I can put in labs, I can put in chief complaint into the search bar. So anything can kind of trigger to get me to the right place. But what I want to know is, okay, what do I do with this man? And do I need to refer him? Should I start him on anything? So we have this algorithm, a format that comes through. Again, it's kind of expanded out. So, but anyways, this is the hypothyroid algorithm. We see that his TSH is 48. His free T4 is 1, which is over here on the right. He has not had TPO antibodies. I'm going to go ahead and click that new diagnosis here. And it's going to take me kind of through a thought process of figuring out what to do with the patient. This is also very aligned with guideline-directed therapy. So he's less than 70 years of age. He's experiencing symptoms of hypothyroidism. If I need to remind myself, I have these pop-ups to do that. His TSH is greater than 10. His free T4 is normal, and we don't have a TPO antibody. And what spits out is the logic of what got me to where I am. And then I know what to call this thing. If I'm a brand new clinician, this is something that could be very helpful because it can help me articulate if I'm going to refer the patient of what's going on with the patient. So this is symptomatic subclinical hypothyroidism in a patient under age of 70. And it gives me guidance on what to do. So now I know to order the TPO to get the patient started on the levothyroxine. And then the patient says to me, well, I want to actually I have a naturopath and I actually talk to them and I want to do this thing called Armor, or I want to do the naturopathic thyroid. So we have this integrative medicine insight that tells me how to have a meaningful conversation with this patient who now is wanting to do Armor thyroid. And if he's fully insistent on it, what I can do for the patient and how I can counsel the patient. Then there's this section called pointers. These pointers sections, these are if I went to the doctor's lounge and I ran into my endocrinology friend and I said, hey, I got this patient with this issue. What should I tell him when I'm going to start the thyroid? Well, don't forget to tell him, you should stay on the same brand. And this is when you should take the medication. So we're curating these pointers, which is really that clinical wisdom, the experiential wisdom that we see, many of us that are 20, 30-year veterans in clinical care, we always remember to say to our patients. And we've weaved that into this library. And then this is telling me when I should refer the patient, which in this particular situation, it looks like, hey, I don't need to refer this patient yet. I'm going to go ahead and send this patient, get this patient started. And if any of these things happen after if they're still persistent or anything like that after a couple months of therapy, then I would know to send the patient to endocrine. And then I'm just going to show you one other one. This is the other one that's really popular in Providence. I think it's our most searched algorithm, which is the abnormal liver enzymes. And we're going to have an 81-year-old female. And this is a very common condition where a lot of clinicians see this happening with their patients. So this patient, let's just say, had elevated liver enzymes for more than 6 months. It's telling me to go ahead and, look at some other potential causes of why this could be happening. And then it asks me to put in the pattern. So the pattern is an elevated GGT, but everything else is normal. And then it's, again, spitting out guidance on what to do with this patient. One of the next features that's coming out, this is going to look wonky because I expanded the screen, but is that we are also able to build documentation summaries of the contextualized data and some of the knowledge as it's being put together. So to help speed up the documentation process. Okay, so that is the live demo. I'm going to just go ahead and just talk about a couple more features, and then I'm going to let Toyin talk about the roadmap. I didn't show you the back end of the platform, that GitHub for doctors that I kind of mentioned, but these are some of the features that have been digitally enabled from a governance perspective, because we know that that's really important. The ability to build consensus, the ability for clinicians to be able to weigh in with their thoughts and, of how some of these things should be built, translated, and whatnot. So we have role assignments that we can create. We can create peer reviewers, authors, and contributors. We have audit logs, and we also have version control. So we're able to track every single change that's ever been made, who makes that change. So we can track it down to the keystroke level. And this is really important because obviously you need to know from a transparency perspective where everything comes from. And so we're able to track that. We do have a whole editorial review and publishing process that's digitally enabled within there. So not like anybody can go in there and publish something. It has to go through a review process with our team. We have ability for voting by committees and things like that, and the ability to put in real-time commenting and collaboration as well. We have a feedback mechanism in the front end solution, the UX solution that I showed you, where clinicians are often giving us feedback. A lot of times it's really around adding more content or more topics. And then again, transparency around the level of governance, who it's been reviewed by, when it's been reviewed. So all of that stuff is tracked in the solution. I know you probably saw some colorful things in the platform. We have these weaved in what we call icons that are really insights around pain points that clinicians, this is designed around the clinicians telling us these are things that I want to be reminded of, or that I want to have insights to when I'm seeing my patients. I'm going to talk about a couple of them in a little bit more depth, but this is the current iconography logic that we have today. Red and yellow flags are really, red flag is like, hey, this patient should go to the ER. Yellow flag is this patient should probably get in to see the specialist sooner. And then I'm going to go a little bit deeper on the health equity icon, which we're really proud of, the fact that we've been able to pepper this library of content with over almost 200 health equity insights. We know new research is coming out, and we've got to get clinicians to start having conversations with their patients about some of these things, or the patients are asking about them when they come in. So really designed to kind of bring those insights to the point of care as a reminder to have a collaborative discussion with your patient, or to consider something maybe a little bit differently because of newer research that is coming out. We also have this resource limited icon, and this is really for clinicians who are out in rural and underserved areas where they don't have access to specialists. It could be 3-4 hour drive for the patient to get in to see a specialist, or there could be very, very long wait times for the patient to be seen. This is very practical information to help the clinician say, hey, you should try to get the patient to the specialist, but if you can't, this is one more step that you can take with your patient. And this has been very well received as well. We have about 200 of these. We currently are deployed in rural clinics and things like that we're deployed in. We're also deployed in a tribal health authority. So there are places where they just don't have any access, and this is kind of like a lifeline for the clinicians in those places. And then contextualization is also the way that we do the mapping. So within the publisher and the context engine, the GitHub for doctors on the back end, there's this no-code environment that also allows us to map the relevant patient data through a Fire feed to the knowledge base. And that everything that I showed you, everything that I demoed, it's built by clinicians for clinicians. There's no engineers involved in building any of the content or the experiences that we're showing you here. Obviously, we have engineers who build the solution and the software, but we are empowered to manage it ourselves. I just wanted to talk a little bit about just our pilot process. We went live with version 1.0 of MedPearl in 2022, in July of 2022. And during that time, we had about 200 plus 250 clinicians that piloted the product. It didn't have contextualization at that time. It was just the library. And the clinicians, we did about 14,000 searches during that 3-month period. And some of the participants participated in a pre and post survey saying, pre-MedPearl, post-MedPearl, how did you feel about feeling competent and comfortable with managing and referring patients and identifying optimal ways to refer the patients? And you can see that there was a statistically significant improvement pre and post MedPearl in level of competence and comfort with doing that. So that was really reassuring. Then in January, we got approval to make MedPearl available across the health system. So we launched MedPearl across the health system in the end of January, early February of 23. And then contextualization work started to kick off in September of last year. And we completed the full contextualization of the library in April of this year. So now the library is fully contextualized. And you can see we have some pretty good signals and metrics of success here. We talk a little bit more about these in detail in the New England Journal article, but not only are we working to delight clinicians and reduce their burnout, but we're also helping them be more productive and helping them with more clinically appropriate, higher value referrals, which is beneficial to everyone in the clinician community. It's beneficial to the patient. It's beneficial to and satisfying for the surgeons and the proceduralists and the specialists on the receiving end of these referrals. And it's empowering for the frontline clinicians who feel like they're given what they need when they need it at the point of care. And just going a little bit more in detail on our data that we have for the productivity, we were able to demonstrate approximately 22 RVUs improvement per average per month for our top users of MedPearl. And this was with all complete voluntary use and no requirement of actually seeing more patients in order to have the product available to them. So this was really a signal that they're really they're seeing more complex things. They may not be seeing more patients, but they're more empowered to do more with their patients. And then we were also able to demonstrate improved after hours time and EMR efficiency scores in our users. We love getting testimonials and feedback from our end users. This is just a couple sneak peek of some of the ones that we get, but our clinicians really, without prompting and without having to ask, they're selling it to each other. They're talking about the platform with each other. it's something that's really resonating for them at the point of care. So that's been something that gets me up and gets me going every day to work, because I know my mission is to help restore, or our mission is to help restore joy in the practice of medicine. And we love that we're cultivating a product that really is starting to demonstrate that that improvement in the wellness of our clinicians. Some of the things that we learned along the way, this has not been an easy journey, I would say. When I started on this, I am not sure that I knew exactly what I was getting myself into, like building a platform from scratch, from an idea to full scale across an organization. And then now we're working on commercialization. It has been, as Toyin said, we just kind of fall into these things, but it's, I think, just a tremendous amount of passion from all of the people that have been involved in the project. But I would say one of the things that has been most critical in the success that we have right now is the sponsorship from executive leadership, that they understood what problem we were trying to solve, and that they supported us and gave us resources to continue the development. We have had to do, even though it's there, the clinicians are, many clinicians are using it, there's still a lack of awareness. There's still folks that don't know that it exists or that it's there. And so we're constantly socializing and trying to get adoption, even though, our adoption thus far is pretty impressive. We can always do better. I think I talked a little bit about the human-centered design process, placing the end user at the center of the universe. I think that's where a lot of health tech products have fallen so short for so long, is not putting the clinician in the center of the development process for a tech product. And so we really feel very strongly about that human-centered design approach to developing products for clinician end users. I've showed you the ROI and KPI, some of the metrics that are some of the ROIs that we're using, but we have a regular review of our analytics, of our KPIs, of our outcomes. We are held accountable to that as well at the institution level, to ensure that they are getting a return on the investment that they're making. And then Toyin's going to talk a little bit more about some of the things that we're doing with our roadmap that are really exciting going into the future. So Toyin.
Okay, and I have to say it was very exciting for me to join Providence and join this team. As I mentioned, I came from industry. I've worked at, Buoy, an early symptom checker, AI navigation and triage company. And then I was at, Google X and Bridge Bio. So I've, kind of been around the block, as you should say, and venture-backed and publicly traded technology companies. But I think this was the first time where I felt like, this is a group of people who are trying to develop and solve a problem for their own clinicians and by extension, the patients that they care for. So that was very exciting. And Providence, just for folks who don't know, it's huge. We have 46,000 doctors, 44,000 nurses. We're across 7 states in person, 8 if you count our virtual footprint. We did 30 million patient visits last year. It's a big enterprise. And so to be able to navigate that, develop a product, and then have the success that she's had, to the point where this product is actually on the path to commercialization outside of Providence, because other health systems want to use it, is just, something that I had never had the experience with before. So just talking about MedPearl, so it's been used by about 7,000 Providence physicians, APPs, and other care team members. And just so you know, that the primary user on the initiation of the product is primary care clinicians in ambulatory care settings. So this is actually most of our primary care clinicians internally at Providence. They've conducted over 330,000 point of care searches. And again, this product has only been scaled across Providence. We're just not even at the 2-year mark. And then there are about 1,000 guides and algorithms that are, again, written and governed by clinicians. And then I want to get into the roadmap and then open it up for questions. So if you go to the last one, Evie, really quick. So, I think when Evie started the product, of course, as she mentioned, the referral management and access problem was the key driver. But I think we all know very clearly that there's just a responsibility that whenever you're making a health technology product that touches caregivers and by extension, the clinicians that they serve, that your responsibility continues to loom because we are really at the forefront of the physician shortage, right? Like over half of all practicing physicians are experiencing burnout. 20% of physicians will leave the workforce in the next 2 years. Given just our portfolio and reach within virtual care and digital health, we even closely know like when fellowships are not filled because we know that those fellows are not going to become clinicians that can practice in our system. We have regions within Providence in Northern California, actually in the Eureka area, where it might take 10 years to fill a specialist. That's like 3 hours from where we live right now, right? So this is a real crisis, right? And folks are burned out, they're retiring early, they're reducing FTE, they're going into non-clinical roles. And so a lot of the gaps are going to be filled by advanced practice and allied health professionals. So the ability to sort of rapidly onboard and train and upskill less experienced clinical workforce is like pretty tantamount and scopes out what we're trying to build beyond just the initial NIDIS, which was the referral management system. Next slide. So that might kind of explain our roadmap. So we're doing all sorts of stuff and we can get into each of them in detail, but I'll just give some of the highlights that might be relevant for this group. So as you imagine that the product initially started with clinicians writing and then governing their own content, but you know, with the advent of large language models, we're working through the process, and I'll get into that a little bit more about the combination of automated and human written content. And so how do we speed up that content creation process? We're also looking into, as you saw how Evie, when she did the demo, how right now there's two main things. One is that we're a search-based experience, but because we have the clinical information and the clinical data moving to less of a search-based experience and more of a push-based experience. We actually know who the clinician is, who the patient is. We have the clinical knowledge and we have the clinical data. So how to combine all of those together to start saying, not just you think the patient has hypothyroid, but we actually think that too. And so let's surface this guide for you. Also going down those algorithms that you saw her like tapping on right now, she is doing that, but I can't show it to you, but we can do that, you know, and tap those algorithms based on the clinical data that we have. And then, you know, start saying things like, do you agree with what we're showing? Is this the right, you know, clinical condition that you think it is? So we can get into a lot of that in detail, but there's a lot of cool work that we're doing on that with our internal ML and data teams. And then just other things like continually working to expand our library to make sure it's the most up-to-date content for our clinicians. Right now, as Evie mentioned, we are an Epic shop. We are the second biggest instance of Epic in the nation. So we use so much Epic at Providence. So we are really tailor-made for that EMR, but how do we expand beyond Epic into other electronic medical records is something that we're working on. And then lastly, we are also a big user of ambient dictation software. We actually have the most licenses of DAX Copilot, so we are a big user of ambient dictation. So how do we integrate our technology with ambient integration just through the audio stream is going to be another interesting thing that, again, I can do deep dives into any of this, but that's actively something that we're working on as well. Next slide, Evie. I'm talking fast because I want to leave time for questions. I just wanted to talk a little bit about like how we view AI in our content creation process. And this is something that I think is kind of where the rubber meets the road, because it's, as someone who's worked external and internal to a system, external, you're like, let's AI everything, it's going to be amazing. And then internal, you're like, there is a significant amount of guardrails and governance that health systems, who are the ultimate users of the technology, have to go through to have these technologies at the point of care. Evie and I both know, because we sit and lead our clinical AI guardrails and governance group internally. And so we have really crafted this with the point of view in mind of how we know health system customers think about AI in terms of what they want their clinicians to be using. And so I think we have a really strong foundation because we have the medical knowledge and the patient data, and we've done a lot of validation internally with our clinical expertise to be able to utilize AI technologies really thoughtfully while still making sure that we center the clinical expertise that has enabled the trust to have all of these clinicians use it in the first place. And then lastly, I just wanted to show kind of what we're doing in terms of our sort of how we are using AI right now. So all of our content creators use publicly available AI tooling to create and generate the bibliographies. If you think about just how do you write medical content, usually you start with step one, a clinical query. What do I do with a patient that has knee pain, right? Knee pain. And then often the individual will go and do a literature review, knee pain, PubMed, right? And gather articles based on relevancy to their clinical query. They'll then generate a content draft that they want to make sure is accurate and standardized and doesn't have any plagiarism concerns and is fully referenced. And then they want to actually turn it into the MedPearl way, which is making it actionable. We don't just write a medical corpus. We're not a content management system. We want to make it actionable like she showed you, because our clinicians are busy and they need to be able to read this content in 2 minutes or less. That's the pressure that we put on our content writers. And so that is a very systematic process by which they write content. And so right now we are, effectively systematically replacing each of those parts of the content creation process with various AI technologies. So for generating bibliography, right, you can use various tooling, like you guys all know, Open Evidence and Perplexity and things like that. And then now we're moving into how do we actually work on the content drafting and making sure that it's accurate, referenced, and there's a lot of off-the-shelf tooling that can do that now. And then lastly is making the algorithms with AI technology. At that point, we've done a lot of testing. We have internal at Providence, we're lucky we have our own ML and data teams as well. We're not there yet on the algorithms, but all the other steps we are there, and we are utilizing that today in our workflows. And so that has been really exciting because that technology came out while this product was being made. So it's been really great working on it and being able to incorporate some of that stuff. So I've been blabbing on for a little bit, so I think I'm going to pause there with this quote, actually, that Evie likes to say a lot. And it comes from Rod Hochman, who's our outgoing CEO, and he himself is a physician. And this is a quote of his that says, "Workplace innovations that ignite the joy of clinical practice and enable deeper human connection with patients will play a key role in navigating the healthcare labor crisis." This is something that Providence feels very strongly, is how can we utilize innovation to help our caregivers and by extension, the patients that they take care of. So it's really been a privilege getting to work on a technology like this that has such a big impact. So I'm going to stop there and share screening. I think, Evie, we could probably stop sharing our screen and open it up to questions so that we have enough time. We love a question. We love a question.
Thanks. And we already got a couple queued up. Blackbird Middleton, I'm going to bring you on in a second. But first, there was a quick anonymous question. This had to be some kind of partnership with Epic, right? You're able to get real-time data. Like, that seems hard to do. What did that involve?
If you say Epic 3 times, they will show up and you will get in trouble. So let's just say, I think, like any other technology, they started by making it scalable outside of Providence, right? So some of that clinical data with Epic, if you're using public FHIR APIs, you can use that, no problem, even in a product that's going to be commercialized. And you are at Epic able to use private APIs as long as it's just for the internal use case of your caregivers and clinicians internally. So that's always the sort of distinction I like to remind people, is if it's a public API, which is available, anyone can read out data from Epic on public APIs in their FHIR marketplace. If you're using a private API, that can only be done if you're doing it on your own instance of Epic and not doing it in a commercialized fashion, unless, of course, you have worked with Epic ahead of time to enable the use of private APIs in a commercialized product. It's really easy to read out from Epic. What's hard is to write back into Epic without using a private API.
And right now, all we're using is open FHIR APIs. So we are in the Epic marketplace. So we did get accepted as a vendor in the Epic marketplace, and so we are starting to deploy in a couple other health systems. So they're able to pull it from the marketplace and deploy in their system. But we didn't have to have a specific partnership with them in order to be able to do what we're doing right now.
Great. More to follow up there, but Blackford, I think, is in the queue for a question. Blackford, do you want to go ahead?
Yeah, can you hear me okay?
Yeah.
Yep, go ahead.
Well, look, thanks very much, Eve, Toyin. That was terrific presentation and a problem I've been thinking about almost the entire life and practice. I've been at it. You know, I think one of the critical challenges is this idea of knowledge interoperability or portability. So you guys have created a phenomenal, knowledge base. I'm just curious about what is the underlying representational formalism, if you will, for that knowledge? And then how do you actually do inference? Is it more deterministic or less deterministic?
Okay, so I'll take that. So the way that the knowledge base initially was created was, I would say, like not computable because it was just text that was written, and the publisher was more of like a collaboration tooling to enable that to be done. And then what then ended up happening was that folks said, okay, well, we want to incorporate clinical data in order to make that knowledge base like more actionable to us. And so then they created that contextualization engine that she was showing you that is proprietary and is not like what you would do outside of Providence, which would be just to go to like UMLS and use like Loink and SNOMED, right? Like what they were able to do is, I think what most people don't realize is that even at the individual lab level, sometimes they'll use like observational names, or they will use like generic miscellaneous CPT. That's like the most common used CPT is actually the miscellaneous one. And so because we were doing it internally, they were able to create their own, I would call like ontology that includes Loink, CPT, SNOMED, and observational names. And so those are then mapped, so initially they started with that, and then they mapped the observational names from within these widgets they created to the observational name within the actual words of text in the guides that were written by doctors. And that was done as actually an automated process. They actually had people like red boxing individual words with widgets. And then now that with LLMs, we're just doing that automatically on the background with just like named entity recognition to just Microsoft Text Analytics. I don't know if I answered your question.
Yeah, no, that was very, very helpful. Thank you. One quick follow-up. So then inference, given the knowledge architecture, what's actually happening? Is it more rule-based or what?
Yes. So right now it's actually all rule-based. Within even all those buttons in the algorithm, there's like HTML coding in the back end to like make it all rule-based as such. And the point of that was that like, I think that they leverage accuracy.
So Adrian's on the call. He just texted me. Adrian, do you want to answer?
Adrian can answer it too if he wants. He's our little CTO.
My chief technology officer joined the end of the call, so I'll let him answer.
Great. Hey, Adrian.
Can you hear me?
Yeah.
Kind of.
Hi.
Adrian's like, don't let Toyin keep talking.
Toyin was asking that one. So when we architected MedPearl, part of the thinking was some of the core fundamentals of symbolic.
We can't hear you very well, Adrian.
Let me set my microphone. 1 second.
When you say inference 3 times, Adrian's like, okay, she's a doctor. Let me jump on.
Can you hear me? Can you hear me now?
Yes.
Yeah, so the inference today works with kind of the core principles we have around symbolic programming. Basically, we're establishing symbols on the system, on the medical knowledge. The idea was like, let's say CBC. We will mark a particular word and say, these are the different variables you need to look into the system to be replaced. At the moment, it's done with rules. But we are now, in the next iteration, what we are moving forward is getting that particular rule set and I start trying to teach the system with a model like, hey, when you look into a patient chart, these are the sets you need to be looking into, and just basically learn that if this particular guide was kind of codified with these rules, this next guide you are creating might be related to those rules. So please learn and codify with the same ones, what we're calling auto-contextualization. So that's how the inference is happening today. It has required a lot of manual labeling from the doctors, but now we have enough of an asset to actually teach the system to do this automatically. We're also looking into models from a company called Jon Snow Labs that actually looks into this. They're able to identify ontologies within the text and say, this is a medical term. Do you have any code related to that? So that's basically how we're approaching the problem these days. But in the past was basically with a lot of work from manual labeling.
Adrian, do you want to also describe the fact what we showed you doesn't need to be custom mapped in every health system because of the way that we built the context engine.
Yeah, so I mean, everything is obviously relying on the FHIR endpoints that they tend to be standard across the EHRs. So what we do when we get the vast majority of the structured data, we look into the data in a way that we try to find these patterns that really match other stuff we have labeled in the past. So it tends to be highly accurate, as Toyin was describing, especially with billing codes. So that's actually sufficient to really make it work for everybody, because you might have, if you look into the end-to-end, let's say a blood work machine, they might or might not configure the codes properly regarding low-income and other hierarchies, but I can guarantee you that the healthcare system will make sure the billing codes are right. So using that kind of logic, we are able to say, well, with this particular billing code, we already deduce is let's say, blood work, and this blood work actually maps to low-income, and low-income actually opens the hierarchy of coding, and it helps us to get the detail. There is a hypothesis that we may be able to tap into the UMLS ontology to actually do this all the way down. But we have not found yet anybody that is using the ontology properly across the EHR. Most of them is either CPTs or, of course, low-income codes.
Great. Other questions in the room? Otherwise, I was going to follow up with a couple. He's off camera, but order of go ahead, ask your question.
Very exciting presentation and exciting product. My question is related to, it seems you are using three main sources, the patient data, clinicians' knowledge, and the AI power. I'm wondering how these three sources are integrated to create your outputs, and what percentage of work comes from the patient's data, and what percentage comes from the clinician's knowledge and rule base, and what percentage from the AI. I would like to see what's the impact of the AI, because this is AI powered, and what percentage of your work comes from the AI. And have you ever evaluated this product with the question answering, for example, the LLMs? Because the LLMs also provide all this information by question answering, maybe can provide actionable. And I'm wondering, have you ever evaluated and clinicians' experience about using the both products, LLMs or, for example, your system?
So I'll start with the answer for that. So the content that you're seeing today, the majority, the content is generated. It's a very human-centered approach to content generation today. And I think Toyin explained that there is a step-by-step process that we're going through to start to leverage more AI. We're using AI tooling, I would say, in different places, but not to generate the actual content itself. And the reason why is because there is not acceptance within health systems today for LLM generated content.
Yes.
So that's one piece. There's like a lot of rules, especially around, LLM generated content for clinical decision making that influences clinical decision making. It's really not something that's widely acceptable. In fact, most health systems that we're talking to would not use this product if it was LLM generated content. So they're actually saying that that's not something that's acceptable in their system. And then the second piece was around, so what we've found is that our team experiments with LLMs, though. We try to ask questions, try to get it to generate first drafts for us. So we've been experimenting to see if we can get down the path of being in a more supervised content generation process versus what it is today. And we have not been able to successfully get it to build the content in the way that it's structured today. The other thing that's important is that with an LLM, you have to know what to prompt the LLM. You have to know what to ask it. We have a lot of clinicians, especially our newer graduates, our advanced practice clinicians, allied clinicians that don't always know what questions to ask. They don't always know what to prompt. So the way that the content is organized today is that it prompts back to the clinician. It asks the clinician's question as they're going down a topic. So it's kind of a back and forth process today, which we haven't seen LLMs doing that in effectively in clinical decision support today.
And
But
one
just
comment.
oh, go ahead.
Go ahead.
Adrian.
Go
Oh,
ahead.
yeah, just one comment. So we obviously been toying with the summary of the patient and running that over. I mean, at the moment we are only allowed to use OpenAI because the current how it's configured for Providence and things like that. But when we actually got the summary patient with our own contextualization engine, meaning for like, hey, these are the conclusions of the patient, this is how the patient is doing, and go and run it over an LLM. When you run those experiments, some of the stuff you're getting back from, hey, no, I was looking into, let's say, cirrhosis guy, and this is how the patient is doing. All the feedback we get from doctors with those experiments has been like, the LLM tends to get the things right, but quite often the LLM kills the patient. They actually do something they're not supposed to be doing. So we have not found any successful experiments so far with our own contextualization engine in which the LLMs are actually giving really accurate recommendations of what to do with the patient. And that has been obviously in a playground. We have never done that with real patients, like copying summaries and things like that. So I think there's a lot of work to do. However, in the moment we start labeling, you look into the patient in MedPearl, this was the context, and you took this decision as a doctor, that is going to open the opportunity for future patients to say like, hey, similar patients with similar conditions, can the LLM now infer do an inference conclusion of this patient should be treated in this way? That's what we are hearing somehow, basically suggesting eventually what you're supposed to do. But right now we're only recommending the actions because we don't see LLMs performing the way we want.
The only thing I wanted to mention is like, you know, my perspective, I've been in the startup world, I've been, you know, here and like, because like this is a product at scale being used by clinicians every day at the health system, we do have to follow our AI guardrails process. And I think that's something that I did not really understand when I worked at a startup. I was like, oh, we're just going to make this and people are going to use it. And now they're like, we're not going to use this. And we actually underwent a pretty robust voice of customer where we interviewed CMIOs and CMOs at 15 health systems in a blinded process outside of Providence. And 100% of them actually said they would not use it if it was AI generated content alone without a human in the loop at every the development of every single topic, which also surprised me. But I don't know if folks like always realize the discrepancy between the bleeding edge of technology and then the rubber meeting the road of actual implementation across an entire health system.
Thank you.
Great, we only got 1 minute left. I wanted to squeeze in a couple. We're not going to make it.
Yeah, we can talk fast. Squeeze it in.
All right, double time. I want to say what a little bit like the liability of CDS. Well, like a human curating, they can be wrong sometimes. It may not apply. So who's responsible there? What I really want to get to is you're talking about the ROI for clinical decision support is actually really hard to justify. But Correct. It sounds like you've actually done a pretty good job here and made that very concrete in a way. And I've certainly bought into it. But how do you get health systems, although health systems outside of Providence want to buy this when you're just providing clinical decision support, which seems like should matter, but the business case has been very hard to justify forever.
Well, that's why we focused on referrals.
Yes.
That does speak the love language of the CFO. If you can get, so I remember talking to one of the CFOs and he was like, I don't want my cardiologist seeing established patients. I want them seeing new patients and ordering echoes and doing stents. I want my knee surgeon doing knee surgery chained to the operating table. I want, you know what I mean? And it's like, that's like what they want. And so when they're saying, I'm seeing all these people I don't need to see, or I'm seeing all this non-surgical stuff, like, and that's like a triaging issue and it's a knowledge sharing issue. If you can help solve that, that is their clinical decision support is built into it. And there's all these other halo effects and benefits and different use cases. We're already even doing inpatient use cases too with this. I mean, you don't have to just use it in the ambulatory setting. The platform is designed for every care setting. But yeah, I mean, you gotta like, you have to, okay, you want to solve a problem, which is knowledge and clinical decision support. Okay, what's an ROI that's going to hit the mark with the CFO? And let's like make sure that's included. The other thing that we're building in, which we didn't talk about, is coding and RAF scoring capability.
Yeah, that's a big one.
Yeah. And that one's going to just, you know, ding, 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 ding.
But I will say that was the one thing that was very helpful with having Evie be the founder. I don't know if she mentioned it, but she was the CMO of corporate development before this. So she was doing all the due diligence of technologies before they scaled. So she kind of like snuck in, like, this is what I want to do, but I know that it needs to get done. So we need to have an ROI, right? And a practical tip for those building is while you're internal to a system, that is the best place to justify ROI because you can like ETL to the snowflake and pull the patient and pull the doctor and pull the RVUs. Like it's also easier for us to do that internally because we know who the person is, we know who the patient is, and we can follow them down things like downstream contribution margin and stuff like that, which again would be much harder to do if you were building
the
it outside of a health system because you don't have that data to be able to prove out your value prop. So we were also very lucky to be able to do that because we have all of that data on the clinicians and how all that money flows.
So this is fantastic. I hope we can follow up as well with the last conversation. Really respect and appreciate what you're doing. Any last comments, and then we'll let you go. We're past the hour.
Oh, we need a last comment, Evie.
Thank you.
Thank you.
Thank you so much. Thank you.
Thank you. We'll follow up soon. Thanks so much. Take care.